2, 1. We are now live.
Good evening, everyone. Welcome to the platform of Orthopaedic Research Education Foundation India, and we are here today with our next class on Cubitus Varus. Dr. John Mukhopadhaya, sir, the chairperson of OREF-INDIA, is taking this topic for you. So over to you, sir.
Thank you, and good evening, everybody. Today we're going to talk about Cubitus Varus Deformity post-supracondylar fractures, which is one of the most common deformities that we have to deal with. We all know that the varus deformity of the elbow is something that we see quite commonly in our outpatients, and it's most common after humeral supracondylar fracture. This is a deformity for which very often corrective osteotomies are done. Unfortunately, the results are not always satisfactory, and in spite of surgery, we very often see patients who have a deformity that has recurred or has not been adequately corrected, or however, the patients are very often not satisfied with what has been achieved. The carrying angle is something that is present in almost all of us, and it varies. It's a little more in girls than in boys, and apparently is present since we are in utero. So pretty much through the life of any person, you do have a carrying angle at the elbow, and this remains till you are old and almost more or less all your life. Also, this is the most common complication after supracondylar fractures in children. It's obviously a result of a malunion because there's been some displacement which has not been adequately corrected. Very rarely, you may have some growth disturbance, and possibly due to some disturbance of the trochlear growth, either due to AVN, but this is unusual. Most often, this is a relatively static deformity. What is important to understand is, unlike the distal radius fracture in a child, which tends to remodel significantly, there is very little remodeling in the distal humerus fracture. You may get some remodeling of the posterior translation, but the varus tilt or the rotation does not remodel, and therefore, once you have a deformity, it is more or less there for life. And this study in the JPO really looked at the remodeling capacity of the distal humerus post-supracondylar fracture, and they found no significant change in the relationship between the Bowman's angle on the 14th day after osteosynthesis and the last follow-up visit. So over a period of 2, 3, 4 years, there was really no change in the carrying angle. So once you've done an osteotomy, or once this deformity occurs, the chances are that it will not change much over a period of time. Okay, now what do you find when you see these patients is this deformity at the elbow, which really looks like like an old, the loading stock of an old barrel gun. So that's what it looks like when you look at it from this front with the arm out. It really looks like it's the shape of a long barrel gun, and therefore it's got the term the gun stock deformity. Okay. You also very often have an element of hyperextension, and interestingly, this seems to exacerbate the deformity somewhat. So if you also have hyperextension, possibly because of a slight posterior tilt that remains post-treatment, that tends to exacerbate or exaggerate the deformity. When you examine them clinically, you also find thickening and irregularity of the supracondylar ridges. with the lateral condyle appearing more prominent. There's obviously a decrease in carrying angle, as we mentioned. And if you look at the 3-point relationship, it's interesting that when postgraduates are taught that in the supracondylar fracture, as opposed to a dislocation, the 3-point relationship is maintained. However, once you've got the deformity, there's a callus which forms, and therefore what you feel on the lateral side is not really the lateral epicondyle, but very often the callus and the prominence there. And so when you actually measure the triangle, it's not the classical isosceles triangle that you would expect. And therefore, it's the 3-point relationship, although people talk about it being maintained, is not maintained once you have a cubitus varus deformity. Okay. Also, interestingly, this is a triplane deformity. The worst ones are often a triplane deformity where you have rotation in different directions. You have a horizontal internal rotation, a sagittal posterior tilt, and also a coronal tilt. So you have internal rotation, a varus tilt, and a posterior tilt. And the deformity is really a result of all these 3 rotations combined. Okay. So in most of these situations, you will have really a triplanar deformity. Rarely when you have a true varus impacted fracture, which is in fact commonly missed because or felt that it is something that doesn't need treatment. But if this varus impaction is significant, very often they do end up with a cubitus varus deformity. And in these situations, it might be a pure varus tilt because of medial comminution and impaction. Okay, so this would be a situation where the deformity is more or less uniplanar because of a medial greenstick collapse. Now, people have tried to grade the deformity from depending on how much the varus deformity is, starting from what is the loss of the physiological valgus angle. So the arm is straight, but is not actually in varus, but is relatively in varus because the normal elbow is at valgus, going on to the most severe grades, which are more than 20 degrees of deformity. And this was written about by McCoy et al. In 1970 JBJS. Sorry, 1988 JBJS. So as we said, that this varus deformity or the cubitus varus deformity does not improve with time. It is when they are children or when they present to you, mostly a cosmetic deformity. So essentially a cosmetic deformity when they present to you without any functional impairment. Some of them have some stiffness, especially if they've had sort of vigorous physiotherapy, etc. But usually it is they get back movement, but the deformity can be ugly. So it's essentially a cosmetic deformity. And when you're doing your correction, it is essentially for cosmesis. Therefore, it's important that if you're doing surgery, that you try and get back a good form. That means the elbow should look good at the end of it and should not continue to look, or you should not just do a partial correction, which still looks like it's in varus. Okay. However, if you look at long-term sequelae, the varus deformity is not just a crooked elbow. It doesn't mean every cubitus varus is going to have problems, but in long-term studies, especially the most severe deformities do have problems. Sean O'Driscoll has talked about the posterolateral rotatory instability which some of these elbows develop. Tardy ulnar nerve palsy, again, not common. We have, over the period of the last 20-25 years, had to operate on 2 cases of varus deformity with tardy ulnar nerve palsy compared to the numerous ones that we've had to do for cubitus valgus. You can get triceps dysfunction with which has been written about by Professor Sandhu from Amritsar. You can get dislocation of the ulnar nerve or a recurrent kind of subluxation of the ulnar nerve. Shoulder dysfunction and even posterior subluxation of the shoulder has been described, and you get a predisposition to fractures of the lateral condyle. So we've seen quite a few in our practice where patients have a previous cubitus varus and they end up with a lateral condyle fracture. And some of the lateral condyle fractures which come to you later, which have a varus deformity and you don't have a history, you might mistake it for a varus deformity as a result of a lateral condyle fracture. So here's an example. This is from Professor Wilkins, where there's a lateral condyle fracture in a child who's already got a varus deformity post a supracondylar fracture. Now, the surgical correction, once you've done your clinical assessment, you've counseled the parents, usually these are children, so it's the parents, but if you're doing it in adulthood, then obviously you need to counsel the patient. Remember, there's a huge variety of osteotomies described, and therefore, it is a sign that none of these are absolutely satisfactory. Okay, so you must counsel the patient or the parent that at the end of surgery, it's very rare that the elbow looks exactly like the other elbow. You get correction of the deformity, it'll look much better, but very rare that if you look very closely, that you cannot make out some difference from the other side, especially when they've come late. Okay, the scars can sometimes be prominent, and with girls especially, this can be an issue, and so that is something that needs to be explained to them. And all these surgeries have a significant complication rate, so that's also another thing that needs to be explained to them. Okay, now for the corrective osteotomy to be suitable, they should be easy to perform, should be effective, they should be devoid of major complications, or the complication rate should be low, and your results should be consistent. Okay, so whatever method you use for your osteotomy should give you a good correction every time you do it. Okay, now the question is, these children can get it at the fracture at various ages, starting from as young as, in fact, you can even get a transphysial separation, which is akin to the supracondylar fracture in the neonate, but usually it would be more common as the child grows older, after the age of 3 or 4. But the surgery is usually delayed till they get back full movement. So that can take 3 to 6 months usually. Can take longer, but you should wait at least 6 months, I would say, and probably about a year. That has been suggested by Voss et al. In their paper in 1994. Now, earlier people used to say wait till the child gets to 11 or 12. That is really not necessary, because I think as you wait longer, then the remodeling potential comes down. So don't wait that long. Wait about a year. The reason is twofold. One is to get back full range of motion, and you won't want to rule out that it's a progressive deformity. Okay, so because if it's a progressive deformity and you correct it, it is going to recur and you're going to get the blame for it. So if you have a progressive deformity, it's important to document it before you do the surgery. This paper by Jain et al., Professor Jain from Delhi, suggests that 6 to 11 is the most appropriate age, partly because it's easier to fix at this stage because you have adequate bone stock, and you want to do it before 11 because after 11, the remodeling potential comes down. There are, like as I mentioned, significant complications. Of course, infection depends on your kind of setup you're working in and should be low, less than 1% ideally, because it's an elective surgery. You can get loss of fixation and loss of correction. I think this is probably the most common complication that we see after this. Elbow stiffness, again, not uncommon unless the elbow has been stiff before, or they've had to try post manipulation, or there's been some delay in the healing. Nerve palsy is surprisingly common in the literature. However, as if you look at the various papers, close to 80% are transient and tend to recover. Brachial aneurysm, artery aneurysm is a rare complication which you can get if you're fixing with K-wires and your K-wires come out too far out of the bone. This is something that you have to watch out for when you're doing it. And lateral condylar prominence is something that happens with almost every lateral closing wedge osteotomy. So there are different ways to try and reduce it or avoid this lateral prominence, and we'll discuss that. Now, there's a whole range of osteotomies, as I mentioned. Broadly, they can be classified into the medial opening wedge, the lateral closing wedge, the dome osteotomies, and complex osteotomies, as well as distraction osteogenesis. Now, the lateral closing wedge osteotomy has various variations, which we will talk about during the course of the talk, okay? The medial opening wedge has been advocated by King et al. And Professor Sandhu as well from Amritsar. And it has some merits in that you get back your length and it improves the triceps pull, and you will not get the lateral prominence that you get with the lateral closing wedge osteotomy, or at least will not increase the lateral prominence, which is. However, when you do that and you're increasing the length of the ulnar side, there is increased risk of ulnar nerve palsy. And if you're using a graft, it needs a separate incision for the graft, okay? And the other thing that it's been found is that the length of the arm is really of no functional consequence. So overall, the risk and morbidity overweighs the benefits of the medial opening wedge osteotomy with bone graft. So what is the most common method is the lateral closing wedge, initially written up by Cotton, popularized by French. French described a technique where you did an incomplete osteotomy and you use 2 screws with a wire around it to fix the osteotomy, and subsequently multiple papers have come out on the lateral closing wedge. Okay, so which is probably the most popular. One of the sort of tenets of this is to try and keep the 2 limbs of the osteotomy equal so that you have good contact of the bone. Okay. One of the problems is to try and get low enough with the osteotomy, because very often the supracondylar fracture is much lower than where you do your osteotomy. But the lower you go, the more difficult it becomes to control the distal fragment. And you can fix this with simple K-wires. It is very often done to do it from lateral side itself, or do medial and lateral K-wires, as in this case. Okay. Now, remember this bony prominence that tends to occur when you do this osteotomy. So you can see that, and you can see the reason for it. When you're doing this at a young age, very often this will remodel over time, but initially can look quite prominent, and parents complain about this lateral prominence, but you have to explain to them that it's likely to remodel. Now, you can also do lateral closing wedge with concomitant rotary correction. Again, there's no unanimity in the literature, and various people say that you should do it, and others who say that you do not require to do the rotatory correction. Interestingly, the French osteotomy actually allowed you to do some rotatory correction, because if you wanted to correct the rotation to some extent, you could put one of your screws back and this one front, and when you corrected it, there was some external rotation of the distal fragment. So here, as you see, it's an incomplete osteotomy. You kind of snap the lateral, the medial cortex, so the periosteum is intact. And then you put wires like this. This is from a picture in one of the articles. So do that, and as you tighten the wire, you actually close the wedge and tighten the wires, and that will hold your osteotomy. So we did quite a lot of these earlier, but we found that we tended to lose correction sometimes very often it was hard to keep the medial cortex completely intact, especially in the more severe deformities. And so we've started using a slightly different method of fixation, which we'll show you. The dome osteotomy is another method which has certain advantages in that it allows you to correct more deformity without having to take out a large wedge of bone. So what you do is you do a dome osteotomy and derotate the distal fragment or valgicize the distal fragment to correct your deformity. This would be done usually with a posterior approach as opposed to the lateral closing wedge, which is usually done with a lateral approach. Again, this will also cause some prominence, which tends to remodel with time. Okay, so this is the dome osteotomy. Now, the various modifications, as I said earlier, and I'll just go through some of them. One is to actually move the apex of the wedge distally. So you do more like an oblique osteotomy, and then you can translate a little bit so that your lateral, so you're pulling this way so that your lateral bump is not as prominent as that. The other thing is to perform a step cut and put a screw across. This will also reduce your lateral bump. Various methods of fixing these osteotomies, including, so you can use external fixators with the standard frame. There are specially designed fixators for the supracondylar osteotomy from the AO. And you can even use cement as a post. So you put in your wires, do your osteotomy, do your correct, and just kind of fix the wires with bone cement. As it sets, it will hold it adequately. And this paper shows that they were able to get good results using methyl methacrylate cement to fix these. Okay, so as I mentioned, there are a lot of various osteotomies with slight variations, with some advantages and disadvantages. And you can have the lateral invaginating peg, known as the LIP osteotomy, reported by Butt et al. In JPO, that was from India. The double dome osteotomy, this is from Saudi. The closing wedge counter shift osteotomy. Another one, translational step cut osteotomy. This is from the Shriners, and this is how that is done, where you do a complex wedge with a cut of the bone on the upper part. And then as you correct the deformity, you can translate your bone medially so that your deformity, the lateral part, is not as prominent. Plus, you can do rotatory correction at the same time. Okay. Now, I talked about the distraction osteogenesis. You can do it with the Ilizarov fixator, or if you really want to be very accurate, you can use the Taylor spatial frame, which can exactly dial in the correction that you want, and the software will allow you to correct to the correct extent. This also gives you the option of adjusting your correction till you know that the elbow looks okay. So the external fixator or the gradual correction has that advantage. Now, more recently, we've come to the idea of 3D modeling and 3D sort of designed jigs, which are, you have a jig which allows you to cut the bone as it's supposed to be cut, as well as specially designed plates to fix your osteotomy. So this study by Japan talks about these 3D corrective osteotomies using a custom-made surgical guide and plate. And so this is the sort of way things are moving as we get more and more sophisticated, and people expect more and more perfect correction from these osteotomies. And that's the kind of jig that you have, osteotomy that you can do. And so it's like a osteotomy in a desired plane, which will correct all the elements of the deformity, and then you can fix it with a specially designed plate, which will allow you to put in screws through your through wherever you want to. So after all that, we come to what we do in our setup mostly, or what I do in our setup is having experienced various difficulties and challenges over a period of years where I was not always satisfied with the results. What we tend to do is use a lateral incision, a lateral based wedge. But what we do is we actually do a complete osteotomy. We derotate the distal fragment. We also translate it medially and close the wedge. So it's like a combination of the rotary correction as well as translate it so that the lateral prominence is not very much. And then what we do is we fix with K-wires, which go from the distal fragment to the opposite cortex in the proximal fragment. But we also do a tension band wiring with a screw to these two wires. Okay, so it's a figure of 8 wiring with tensioning that wire so that it reduces the chance of any sort of recurrence of the deformity or loss of your correction in time. So I'll just go through some cases showing you how we do this. And then in the older patient where we use plates. So here's a young boy, 1 year after Cubitus Varus Deformity. You can see there's a significant varus there. Interestingly, if you see his other side, it's not, it's almost like a cubitus rectus. So that's the other importance of getting both elbows x-rayed, because you want to correct it only as much as the other side if the other side is normal. Okay, so that normal varies a lot from one child to another, and so you need to have a good idea. Again, you can see the 3-point relationship doesn't remain exactly the same as the other side. You can see significant varus deformity has got full flexion and range of motion. So what we've done is here we've corrected the close the wedge, and then we are holding this. You can see we are hold the proximal fragment with forceps and pull it towards the lateral side. Okay, and while we are doing that, you can see we pulled it to the lateral side. And while we are doing it, we are trying to pass our wires through. And once we passed our wires through, we also do a tension band wiring, make sure that's adequately tight so that this is, you can see it's translated. We don't always get so much translation. We usually aim for a little less. This is the kind of correction you get, and we also derotate it so that you get a good correction in terms of the. So now you can see the post-op X-ray. You can see how it's remodeling nicely over a period of time. There you can see it's now nicely corrected, and that is his final sort of follow-up where the implants have been removed and he's got a satisfactory range of motion and a good cosmesis at the end of it. So I think this method does give us a better correction than this traditional methods. But I think for the milder deformities, a simple lateral closing wedge works quite well as well. And it's the varus part which is more important in the correction than the rotation. If you just correct the rotation, unless you correct all elements of the rotation in a planned way, where it will automatically correct the varus as well, you will not get a perfect correction. So here's another case. Again, you can see how, you can see it's medialized. This is during the healing. Okay, so you can see how now you're getting a good healing with talus. Again, you can see on the lateral how it's aligned perfectly now. And this is a follow-up of the same child and the final follow-up again that we've got. So again, good range of motion, a good correction of the deformity. Here's another child, more severe deformity. Okay, you can see how there's already some element of subluxation in the joint. Here again, you see how we've medialized the distal fragment. Here, unfortunately, we got a little bit of posterior tilt of the fragment. Okay, probably However, some element of remodeling, very little of remodeling actually takes place. Little bit of hyperextension, but otherwise a good range of motion and a good correction of the deformity or a very severe deformity. Now, in older children, obviously these wires are not going to be adequate, and we go to the plate. Again, here we use a similar principle in that these screws actually pull the proximal fragment laterally so that you reduce the lateral bump. And this is him. You can see a good correction cosmetically. Another sort of 11-year-old girl, again, not a very severe deformity, but you can see the carrying angle on the other side and a loss of the carrying angle here, a little bit of hyperextension. And here again, we've used this plate. You can see the slight medialization that you can see here. And again, very good correction cosmetically and a good range of motion. So one last case, which is like the extreme kind of deformity. You can see there's a subluxation of the joint as well. In fact, if you see this, the olecranon is not really articulating properly with the trochlea. Okay, and of course, it's very deformed and very misshapen by this time. But here you have to try to get reasonably good correction. So here we've done a dome. Initially with K-wires, you designed the dome. We've used the posterior approach, taken the triceps off to one side, corrected it, again translated it. Here's the lateral plate. And then we put a second plate because this is almost an adult where you want to get good stable fixation. Here we had to, as you mentioned, get the joint back into the trochlea part. Okay, so we had to put a transarticular wire for 3 weeks to make sure that this didn't go out of place. Again, now you can see it's a much better looking elbow. This is after the wire's been taken out and we start motion. Again, much better looking elbow than the preoperative x-rays. And over a period of time, it took some time for him to get back movement. He also had a post-op ulnar nerve palsy, as you can see here. So once the osteotomy had healed and he got back a reasonable range of motion, we went in and did ulnar nerve neurolysis and translation. And luckily, he got back his function. As you can see, his ulnar nerve function has come back. Now he can fully, his clawing is gone. And he's got back a reasonably good range of motion. I wouldn't say a full range of motion, but considering the severity and of the deformity and his very late presentation, a satisfactory result. Okay, so I think at the end of that, what I would say is that this deformity is not uncommon. It is the most common complication of the supracondylar fracture. And at the time of surgery, it's usually a cosmetic deformity. Of course, when they present late, they may have other problems like cardiac nerve palsy or some other problems which you may have to deal with. Remember that I know many people, I know other orthopedic surgeons who have a significant cubitus varus deformity and are able to do all their function quite well. But some of them can have significant long-term sequelae, which I've mentioned, and that's something you need to be aware of and counsel the parents on. If they want to avoid surgery, that there's a possibility that they can have problems. If you're planning correction, it has to be planned carefully. Try to correct the deformity in a way that it looks as close to possible as the opposite side, and do your best to avoid complications, because any complication is going to compromise your results after this surgery. So thank you, and I'll take any questions that they might be.
Thank you very much, sir. So there is a question in the chat box about
Sure.
Dr. Avinash is asked that the Paley's rule of osteotomy apply while doing corrective osteotomy for varus or valgus deformity of the joint is applied here or not?
So the problem is slightly different, because here, if you look at it, the actual displacement is, if you look at the supracondylar fracture, the classical displacement is a posterior and medial displacement. Okay.
Yes.
sorry, posterior and lateral or posterior and medial displacement, okay? But here you actually, because of the callus, you get a big bump on the lateral side. So you translate to try and reduce the bump, okay? Now it's not like the lower limb where your limb axis matters in terms of weight bearing. Okay, so you're not using the true mechanical axis planning for correction. Okay, you're just correcting the angle and you're translating because you want to reduce the bump on the lateral side and you want to correct the rotation. So this is very different from a lower limb correction where the mechanical axis restoration becomes very important, because if you don't do that, you tend to get other problems with long-term sequelae on the joints. This is more a cosmetic reason for correction. Yeah.
One more question from Dr. Kumar Gautam is that method to prevent this deformity in supracondylar fracture, both in conservative and surgical treated patients.
So I think the important thing is to get as a good correction. That means you must be happy with your reduction. Okay, now if you're doing conservative treatment, it's important that you can flex your elbow to 130 degrees. Okay, it used to be 110, but now they say 130 degrees. If you don't want it to displace, for the triceps to really hold the fracture reduced. Now, in most situations today, we find that with the swelling and all, if you try to flex it up that much, you're going to have problems with swelling or of the circulation. So in a significantly displaced fracture or unstable fracture, today, by and large, it's accepted that you should fix them with K-wires. Usually it's a closed reduction. Very rarely you may have to do a mini open or even an open reduction. Okay? In fresh cases, it's usually a closed reduction. Now, the other thing is to get the correction right, and it's your AP and your lateral X-ray may sometimes look okay, but they could be a rotational element. So you should also check your oblique views to make sure that your rotation is corrected. Okay, because if you have rotation, one is that is part of the deformity. Second is that the moment you have some rotation, your contact area comes less, and therefore what we do today very often is just two lateral wires to avoid a medial wire, and that may sometimes not be stable because your contact area becomes less. Okay, so it may displace. So get your reduction adequate, make sure you get it adequately, check your AP and lateral, but also check your oblique views to see that your pillars are matching, and then get a good stable fixation of, the configuration of the wires, etc., so that you get adequate. If you're putting just lateral wires, they should be divergent. If you're putting cross wires, they should cross with adequate sort of purchase on the bone on both sides.
So, when you decide that it can be treated conservatively, because, sir, most of the time that is medial combination is there. And when you decide to go for open reduction, like in few books, the older book, it is written, if it is type 3, then it's better to go for open reduction.
Yeah, so that's by and large a guideline. Okay, type 3 or type 4, now we talk about type 4 also, definitely need reduction by fixation. Type 2, you can treat conservatively, but you need to look at the swelling. So circulation compromise, or because then it's better to fix these also, because once you fix them, then you can keep them in a cast. Usually your wires outside, then you can take it out. Fixing the elbow. Okay. Okay, and the other thing is the varus. Very easy to trivial. and then their parents upset because no one's told them that it needs. You need to disimpact it. They will tend to go varus because of the medial community.
By Dr. Kumar Gautam is that in medial open osteotomy.
Full does not. So what happens in opening wedge, your biceps. So that's what you're balancing it. But what is more important is the direction that it should be in.
And related to this question, sir, when do we need to, how much it is, if it is.
So it depends. It depends which biceps, but some people personally, I don't like cutting the triceps.
So the next question is,
so I think weeks when we take off the cast. Of motion, and after that but usually we would tell them but usually sometimes
he want to ask something. He's raised his hand, sir. So. Jaswinder, sir.
Yeah.
Another, as you have answered, and neurolysis.
And transposition. Cubitus varus, but of the fracture. They've come without recovery. Okay, but we've had in sheaths in the callus. The really bad. Okay.
So he has written, sir, what
adult, okay? And then leave it to them if they want. Approach, you can go on both sides of the tricep. Deformity corrected. Otherwise, I would just
is that in type 4,
so I would then they will reduce. So, but I'm going to do it without anesthesia. Because all these fractures were managed conservatively. Obviously, a certain number did. Okay, so they do not.
in a newborn with CTV.
So as soon as possible, okay? Today you may wait 5 or 6 days or a week just to see that the child is thriving and bonds with the mother in terms of feeding, etc. But we don't wait for longer. If the child comes early, we start at 1 week. Okay, if they come later, we start them whenever they come.
So when you start,
but you have to be very careful when you are plastering these children when they're very small, because the skin tends to be very sensitive. Also, any force, or if the plaster is tight, the risk of any complications go up. So if you're doing it in a very small child, make sure they come back within a few, but check them again after a few hours and make sure they come back the next day to make sure that there's no problem, and warn them that if there's any discoloration or anything that doesn't, or the child is crying incessantly, to come and get the plaster slit without worrying about it.
So there are a few questions which is asked during the Viva. One is that about the 3-point bony relationship, that sometimes it is called as it is scalene type, or it is sometimes called as scalene triangle, or
isosceles triangle and scalene triangles are things that you should know what they are. Huh?
Yes.
They are geometrical terms. They're not orthopedic terms. Okay.
Yes, sir. Yes, sir. That I have searched on Google, that it is all the three sides is of different length for the skin, but usually it is asked during the Viva, sir. So what about the 3-point bony relationship, sir? Because
so I think if you heard the talk, that's something which I elaborated on. So if you look in a supracondylar fracture, usually the two epicondyles and the olecranon should be in the same relationship. But once they have a cubitus varus deformity, it's not the epicondyles that you're actually feeling on the lateral side. Okay. what you're feeling is the callus that's formed. Okay? And so what you will very often find the distance between the olecranon and the lateral side is much more than the olecranon and the medial side. Okay, because of the callus that's formed. So it's a bit of a fallacy there, and I think examiners should realize that when they expect the answers from the students.
So another question usually is asked about that when there is a cubitus varus deformity, usually the flexion is not adequate what the normal side the child has. So one reason they used to give is about the bony ledge. So what is that bony ledge, sir? Because in different terms, sometimes they used to ask that where is the bony ledge?
Ledge is because, so if you have a posterior displacement, okay, then the proximal fragment tends to jet out anteriorly, okay? So that may impinge when you're trying to flex it beyond a point. So there are situations where people just excise that, but it's rare, huh? Okay. Now, some of the reduced flexion may be because of a hyperextension at the fracture, and you can see them clinically because they have a recurvatum when they extend the elbow as compared to the other side. And then when they flex, they may not have as much flexion as they have on the other side. So there you can correct that when you do your osteotomy by correcting the recurvatum as well.
Sir, okay. So when you are doing that osteotomy, open wedge osteotomy, and rotating it, then
not
that
an open wedge, it's a closing wedge osteotomy.
Oh, sorry. Yes, sir. Close wedge osteotomy. Then at that time, if we rotate it, that is also taken care of, sir.
What?
Or that bony ledge?
No. That ledge is when it's significantly prominent that it really will cause a block. Otherwise, it's most of it is often. So you would have to just remove that. So when you take your wedge, you can remove that as well. If you include it in your wedge, but it's not something that will automatically be reduced.
So
you can plan it. You can plan it in your wedge if it is exactly where you're doing osteotomy. Sorry, what do you say?
So one more thing which I want to ask with this one, when we are dealing with the tertial nerve palsy, sir, and you have mentioned that to do the neurolysis and ulnar transposition, is it necessary always to do ulnar transposition, sir, or we can keep ulnar nerve there also?
So I think if you're doing it for cubitus valgus, then definitely you need to transpose it, because when you flex it, it will tend to get pulled again. I think the fact that you have to make a decision on the table at the end of your surgery, okay, whether you feel that transposition is also necessary, because it frees. Okay, so I don't think it's always necessary, but in most situations, it's not a common problem. Okay, it's not as if you've done hundreds of these and you decide that, oh no, this is better than the other. Okay, so you get tardy ulnar nerve palsy and supracondylar fracture. Like I said, we've operated on 2 in the last 30 years. Okay, so you imagine how common it is. Yes, it's just something that may happen. That's all. It's very unusual.
And so while doing the osteotomy, the one common problem which used to happen, if we want to save the medial cortex, sometimes we are not able to. In that case, the distal fragment is very small. So how to control that fragment? That is quite difficult during surgery.
Yeah, so that is one of the problems that does happen if you do your osteotomy too distal. Okay, so make sure you're proximal to the fossa. Yeah, and have wires in the distal fragment. So I partially pass my wires into the distal fragment before I do my osteotomy. So you have some hold, and the proximal fragment you can hold with clamps. Okay, so if you, it is, so especially when you're doing what we do, there is a risk of it becoming unstable. And so then it takes, if you don't get it right the first time, sometimes you're struggling to get it back again. But that's a price you pay for trying to get the correction more accurate. Okay, but then, so there are these other osteotomies which allow you to, so there are multiple osteotomies with geometric cuts, etc. Pegs which will hold it in position. I haven't tried those, so because this seems to work with us, but if you're not comfortable with that, do something else. I mean, you don't have to do what he is doing. And most of these with a simple lateral closing wedge will look reasonably good. It's in the more severe deformities that you need to rotate it.
I think we have covered most of the questions.
Good.
Thank you very much, sir.
Okay, thanks very much. Bye.
Thank you, sir.
Bye-bye.